What advice do you have to somebody who is intubating a person who is known to have a stent?
Ideally, if you're going to intubate these patients, after discussing the case if possible, you're going to be using a bronchoscope and doing a fiber optic intubation, because that's going to allow you to directly visualize the airway and the stent, and then you can, carefully advance the endotracheal tube, preferably above the stent, so that you don't hit it, you don't dislodge it. So let's say you're in the ICU, this patient has a respiratory arrest. In that case, if you don't have the ability to do a fiber optic intubation, I would strongly consider doing a supraglottic airway. I think they're underutilized in general. They're very effective for oxygenation and ventilation, and it allows you time to get the tools that you need to properly assess the patient.
Welcome to Critical Care Time, the podcast for everyone who cares for the critically ill. I'm one of your hosts today, Dr. Cyrus Askin, joined as always by my co-host, the illustrious Dr. Nick Mark. Nick, how are you doing today?
Good to be here, buddy. It is a snow day in my neck of the woods. So kids are home, which means that I get to be a podcast host, an intensivist, and a home teacher.
Oh, wonderful.
Kind of fun, kind of exhausting.
Yeah, I can imagine. We not surprisingly don't deal with a ton of snow here in El Paso. From time to time, we do.
You have like dust storms or days or something?
Oh, don't get me started on the AQI, man. It's horrible. And then with Juarez being so close, you've got the pollution that kind of blows across, and it's brutal for my asthmatics that I take care of.
Yikes!
Yeah, so I rather have snow, but it is what it is. So
anyway, it was a fun chance to bust out some golden oldies from the garage, like the molecular biology model set from Orgo.
Nice.
Making some water, some benzene. Got to teach something.
Yes, I mean I imagine in just a couple of years, your 9-year-old will be applying to medical school. So
something like that. Yeah.
So all right. Well, without further ado, Nick, what are we talking about today?
Well, we're going to talk about something that we've kind of touched on, but we really ought to say more about, which is, kind of uncharted territory in the world of foam med. Specifically, how do we use interventional pulmonary skills to get out of hot water in the ICU?
Exactly. Yep. Super excited to talk about this because, like you said, it's not commonly covered in a lot of the kind of foam med that's readily available. I will say that this isn't the first time we've talked about the importance of the bronchoscope in the ICU. Previously, when we were talking with Dr. Whitney Warren about life-threatening hemoptysis, we covered it there, and that had a great time kind of exploring it in that context.
Yeah, we also talked with the Pulm Peeps on episode 22 about how you can use the bronchoscope to help yourself out in some dicey airway situations.
Absolutely. So today, we're going to be taking that one step further, and we're going to be talking about how you can use those skills as an interventional pulmonologist or leverage the skills from your friendly interventional pulmonologist to help you out in the ICU.
Since, neither you nor I are interventional pulmonologists, we asked one of our own, Dr. Josh Boster, to join us to talk about this. He's an IP fellow at MD Anderson Cancer Center. He's been helping us out with the show for a while now. So it's good to get him on air to talk about, what he does.
All right, folks, it's always great to be able to host a friend and a colleague on this show, especially someone who's part of our own production team like Nick had alluded to.
Yeah. So Dr. Joshua Boster is an active duty pulmonary critical care physician in the U.S. Army who completed his internal medicine residency, chief year, and pulmonary critical care fellowship at Brooke Army Medical Center in sunny San Antonio, Texas. He's now an interventional pulmonary fellow at the University of Texas MD Anderson Cancer Center. He's also the father of 3 and avid video gamer. He's got lots of things on his plate. Josh.
That's right. Yeah. So Josh, if memory serves, I think one of those daughters is pretty new. Yeah.
Yes, sir. Yeah. My third daughter, Grace, was born a week ago. Thankfully, everything went great. My wife's doing well. The baby's doing well. We're a little sleep deprived.
Of course.
But other than that, things are going great. Thank you.
Yeah, I can appreciate that. We've got our 1-month-old and sleep is a precious commodity. So heart goes out to you. Okay, so thanks for joining us. Maybe we can start by having you share with the audience, a little bit about how you got interested in pulmonary and critical care medicine, and then why you decided to take your talents to Houston to pursue this IP fellowship.
Yeah, thanks for asking. Before I get into that, I just wanted to thank you both for the opportunity to be a small part of this podcast. And I think it's often, kind of a thankless job. So you guys, I just wanted to say that we appreciate the time you take out of your busy days and busy lifestyles to, contribute to the critical care community. So
Thanks.
thank you for that.
Thanks, man.
Yeah.
Right back at you.
Well, thank you. So yeah, I'll apologize in advance. I'll try to give a brief answer, but they're kind of long questions. So for pulmonary critical care, I was actually, on the fence throughout my training. I definitely enjoyed procedures, and so I was considering cardiology or pulmonary critical care. But then, as you all know, the COVID-19 pandemic hit us,
I
and that
recall.
was that was an interesting time. I was a chief resident at the time for our internal medicine residency, and I really felt the need for intensivists as a result of that, and that certainly was something that drew me. In addition to that, my daughter, my first daughter, Evelyn, she was born that time, and she was in the ICU for a little over a month. And I think being on the patient or the family side of an ICU interaction really changes your perspective, and it gave me a big personal respect for what we do, and a desire to contribute. And then lastly, I think, the ICU doctor, as ICU physicians, we really are kind of the last bastion of being a jack of all trades. I felt like cardiology, they really tend to focus on the heart. GI focuses on the GI tract, but when we talk about every single organ system, and we're an expert in them all, at least the critically important part of those organ systems. And so just being able to practice the whole spectrum of medicine really appealed to me. And then for IP specifically, once again, I love procedures, but it's not all about procedures. I had some excellent mentors who you mentioned previously, been on this podcast, Dr. Sobieschek and Dr. Warren. They kind of they showed me the light of what an IP physician can do. And when the opportunity presented itself, I took it. And so the things that make me really excited about IP is there are a lot of ways that we can help our patients feel better and feel better quickly. From a diagnostic standpoint, a patient comes in with a lung mass, they're scared, they're wondering what it is. We can do a robotic bronchoscopy to biopsy it. If they have a pleural effusion that's unexplained, do a pleuroscopy. Lots of procedures to get answers for patients, which helps alleviate their anxiety. And then from a therapeutic perspective, the American Lung Association, they say when you can't breathe, nothing else matters, and that really resonates with me. And so central airway obstruction, being able to debulk that, and patients go from incredibly dyspneic to walking around over Thanksgiving or a holiday, something like that, is impactful. Then also, doing bronchoscopic lung volume reduction. I just don't think I could ever get bored as an interventional pulmonologist. So that's it.
It's an exciting field, and it's an exciting time in that exciting field, right? I mean, it seems like a lot of the things you just mentioned have really developed a lot in just the last like 5 to 10 years.
Yeah, yeah, no, it's rapidly developing, and new things are coming out all the time. And with that development, there's a need to research the benefits and the risks of the things that we can do, because just because we can do something doesn't mean we should. So that's another interest of mine, is doing research. And so yeah, I think 20 years from now, interventional pulmonary might be something completely different than it is right now, and I find that super exciting.
So before we get into kind of the nuts and bolts of what the job entails, and you've done a great job kind of giving an overview of that, maybe we can sort of, kind of define what interventional pulmonary is. My joke is that IP is like being a pulmonologist, except instead of returning pages, you actually have to go into the hospital when you're on call. Is that an accurate description?
Yeah, I would say, the number of times you have to come in isn't so much different than being an intensivist. But yeah, no, that sounds great. I think if you ask 50 interventional pulmonologists, what it means to be an IP physician, they'd give you 50 different answers. But so I'll give you mine. I think it's always good to start up with a little bit of history, and a little bit of trivia. So, by chance, do either of you know who performed the first rigid bronchoscopy?
Was it, I'm reading ahead here, Gustav Killian?
Oh, you cheater.
Oh man, astute observation there. Yeah, so in the 1800s, Gustav Killian, he performed the first rigid bronch, and it was actually to remove a pork bone from the airway of a farmer. And so I think that's great for anyone involved in GME if they're making like a Jeopardy set or something like that. But in terms of the nuts and bolts and what it means to be an IP physician and how you get there, and so as you all know, and maybe for the non pulmonary critical care physicians who listen to this, you have to complete an internal medicine residency, which is 3 years, and then a pulmonary critical care fellowship, which is also 3 years, and then a minimum of 1 year of additional training that focuses on specifically the diagnosis and management of central airway obstruction, lung cancer, pleural disease, and then other specialized procedures, which we'll discuss a little bit more. I think one of the core things that differentiates interventional pulmonologist from a general pulmonologist is rigid bronchoscopy. And so that's something that we are trained to do during our fellowship, and something unique that we offer to the team. Other things on the therapeutic side, placing endobronchial valves, which can be done for lung volume reduction, and also for the management of persistent air leaks, and then sometimes even to control hemoptysis, as I think we're going to discuss in a little bit. Yeah, so lots of things. As we've discussed, it's rapidly expanding, and I suspect it'll continue to change. But it's been a great experience so far. I'm really grateful to have the opportunity to train at MD Anderson, and I would definitely recommend it to those who are interested.
Yeah, I'd be lying to you if I didn't say I'm jealous from time to time when I get your texts, your images, whatnot, of all the cool things that you're doing there. With some really great, visionaries in the field. I know, George Epen and Dr. Casal out there are some pretty, accomplished interventionalists. Several others as well that you've mentioned that are just like, tour de forces in the field. So I think probably a great place to train, and clearly you're learning a ton, which is super exciting. I think we've now done a pretty good job of covering what IP entails in terms of scope of interventions, kinds of things you might be doing. We've gotten to know you a little bit, Josh. So with all that now behind us, I think it's time to get down to brass tacks and just get to a case, because I think that's going to probably help us illustrate not just what you do, but also how those skills can help in a critically ill patient. So, suppose we have a 56-year-old male who's got, bad metastatic squamous cell lung cancer. They're coming in with progressive dyspnea, and let's say they're in the ER. They got a new oxygen requirement, and let's just leave it there. Let's say that's what we got.
Yeah. You saw this
And
guy
then,
in clinic, they're paging you.
yeah, there you go. Exactly. So that's that. There you have it. He's short of breath. He's got oxygen on board, and he's got a little bit of cancer going on.
Yeah, perfect. So, this is not an uncommon thing that we see at MD Anderson. So, certainly, when a cancer patient, especially a metastatic cancer patient, has progressive dyspnea and a new oxygen requirement, that's a red flag for some pretty, important and possibly emergent diagnoses. And so, the things that I would consider, common things being common, would be a PE. As we all know, having cancer increases your risk for venous thromboembolism. So that would be high on the differential. The other thing, metastatic cancer patients tend to get metastatic pleural effusions. And so maybe he has a new or worsening pleural effusion that needs drainage for symptomatic benefit. But, since we are talking about IP things, one of the things that I enjoy having the opportunity to help people with is central airway obstruction. And so, patients with metastatic cancer, lung cancer, or, other cancers that have metastasized to the lung, they can develop central airway obstruction, either from tumor that grows within the main airway, so like in the main stem bronchi, or just distal to that, or in the trachea itself as well. Or, they could have lymphadenopathy that puts compression on those structures, or the tumor itself can also compress those structures. And so, having central airway obstruction is actually much more common than you might think. Up to 20 to 30% of lung cancer patients end up having that during their cancer, I guess, history. And then specifically squamous cell lung cancer and small cell lung cancer, they increase your risk for the development of central airway obstruction because they tend to be more central tumors, as opposed to adenocarcinoma, which is more peripheral and tends to present as the classic peripheral nodule. And so I think in this patient particularly, those would be kind of the three things that I would be most concerned about.
Yeah, I think that's a fantastic differential. So let's kind of narrow it down a little bit with some diagnostic tests. Like what's kind of step number one in working this patient up?
Yeah. So, I think by the time as like a subspecialist that I'm getting called, most of the time, a lot of the workup's already been done. And usually it's a CT scan with contrast to look for PE. And so, as I'm getting called, that's the first thing I'm pulling up because the answer, central airway obstruction, yes or no, something we can intervene upon, yes or no. I want to know that right away. And then I want to know if they have a PE because that's going to affect, whether even if they have central airway obstruction and a PE, that could affect, our ability to intervene. So I think the CT scan is huge, but then also the history and physical. because it'll help us plan our procedural intervention. And so for this patient, the things I would want to know is, if they're on any anticoagulation at baseline. Also, are they on chemotherapy that would affect their platelets, their coagulation factors? And then, when was the last time they ate? Simple things like that, because that's going to affect their ability to undergo general anesthesia. And then more specifically to IP, I would want to assess their mouth opening to see, whether or not I can fit a rigid bronchoscope in there. So rigid bronchoscopes can have diameters up to 15 millimeters. And so we need to make sure that their mouth can accommodate that. You want to look at their dentition, because as you can imagine, when you're sticking a rigid tube in the mouth into the trachea, you could put pressure on teeth, cause damage there. And then you want to see whether or not they can flex and extend their neck, because we like to fully extend their neck for the intubation. So those are kind of the things I would look at most. And then the other things would be, let's say there is central airway obstruction on the CT scan. I want to know if they're symptomatic, because the main role for debulking tumors, they're not bleeding, is to make people feel better. And so I would want to know how they feel. And also, whether or not they've had any cancer specific treatment. So because that'll affect prognosis. As you might be able to imagine, someone who's on their third line chemotherapy that's progressing through it has a much different expected treatment response in the future than someone who's naive to treatment. And so those are kind of all the things I would be looking for.
That's awesome. That's awesome, Josh.
And I'll just point out to our listeners that if you Google your boy Gustav Killian, there are some amazing pictures of like him doing like rigid bronchoscopy on a cadaver where you can see everything in section. We'll put it in the show notes because it's a great illustration of exactly what you're talking about, Josh. The need to open the mouth and then extend or hyperextend the neck in order to put all the structures in a line.
Yeah, the idea of rigid bronchoscopy is always something that befuddled me, just in the sense of like the ergonomics of it. It doesn't seem like the most comfortable position for a patient to be in per se. Although I'm presumably you don't just leave them in it for like hours and hours and hours for funsies. You probably get in and get out. But positioning aside, maybe we could take a little bit of a detour, a moment, because spoiler alert, we're going to say this person has a central airway obstruction. Otherwise, like, I don't know what we're doing here. But before we get into that, why wouldn't you just take like a therapeutic flexible bronchoscope and use that? What is a rigid bronchoscope actually affording you in terms of ability to intervene, diagnostics, therapeutics, etc.?
Or to put it another way, why is a rigid bronchoscope better than a floppy, flaccid, flexible fiber optic bronchoscope?
Sure, yeah, you could put it that way too. I suppose if you're depraved like my colleague Nick Mark.
Perfect. Yeah. So, rigid bronchoscopy, it offers a lot of advantages over flexible bronchoscopy. The first difference being that it is rigid as opposed to flaccid and flexible, as Nick pointed out there. And so, but yeah, one of the main benefits is the working channel. So, as y'all probably know, a therapeutic bronchoscope has a 2.8 millimeter working channel. You can only fit one tool in there. And then if you encounter any major bleeding or other issues, you're kind of hosed, because if you get blood in the camera, you can't see. And if you can't see, you can't intervene and you can't fix things. And so the main benefit of the rigid bronchoscope is the fact that, it's got a large lumen up to 15 millimeters as opposed to a therapeutic bronchoscope, which is 2.8 millimeters. And so that larger lumen allows you to use multiple tools simultaneously to control bleeding, debulk tumors, um, all of which would be very difficult to do with a flexible bronchoscope. But then also, if you're talking about debulking tumors, you need to actually remove the tumor from the airway. And so having a 15 millimeter working channel allows you to remove those large chunks as opposed to through a flexible scope. And then we talked about the visualization issues too. So, with the flexible bronchoscope, you have a camera that it's very easy to get blood onto it and obscure your vision, while on a rigid scope, you have a telescope, which is very easy to remove and clean and replace. So I really do think when you're dealing with any airway procedure that is a high risk of bleeding, having a rigid bronchoscope makes me feel a lot more comfortable that you're going to be able to deal with any complications that may arise. And then also, the rigid bronchoscope in itself is a therapeutic tool. So you can actually use it to debulk tumors. And then once you use it to debulk a tumor, you can actually tamponade bleeding with it. And so it's a very useful tool for many reasons. And then other things about rigid bronchoscopy. So it's very safe. It seems kind of scary that you're basically, sticking a sword into someone's airway.
But people do that, right? I mean, they're sword swallowers. Like people do that safely without anesthesia.
Yeah,
That's
that's
true.
actually the boot camp for IP fellowship starts with that, and
Nice.
then we progress from there.
Nice.
Uh, I think those go in the esophagus, though. We try and avoid that.
Hmm.
Uh,
More of a GI skill set. Got it.
Yeah.
exactly, exactly. But yeah, the rate of complications is very low, like 1 to 3%. And those are in addition to the complications that are associated with general anesthesia. Most patients who are getting a rigid bronchoscopy, they're going to be deeply sedated under general anesthesia, paralyzed, the whole shebang. And so the things I think about in terms of complications are trauma from the rigid bronchoscope itself, trauma to the airway, trauma to the lips, the tongue, the teeth. And so those are all things we're very careful about as we do a rigid intubation. And like I said, 1 to 3%. So rare that there is a complication, and usually we can handle them if they are.
Can I ask a stupid question first, which is just like when you're doing this, how is the person being oxygenated and ventilated? How does that work?
Yeah, so it depends on how they start. So sometimes we're doing a rigid bronchoscopy on an ICU patient who's been intubated emergently for respiratory failure associated central airway obstruction. Those patients sometimes are in very high ventilator settings, and so they're not going to tolerate apnea well. So in that case, what you can do is actually intubate them alongside the ET tube, where you get to the vocal cords, and then you deflate the ET tube balloon, you pull it out, then you quickly intubate them with the rigid scope. And we ventilate with jet ventilation, which is ran by the anesthesiologist. But there's other forms. There's something called a monsoon, which allows you to control the jet ventilation yourself. But I certainly, at least based on my experience, prefer using the jet through the anesthesia, having the anesthesiologist run it, so you can focus on just the patient and your procedure.
And there are, I think we talked about this a little bit before, but any specific kind of patient considerations, like are you trying to select for particular types of patients that would be like good candidates for this, or is it something you could kind of do with all comers?
Yeah, yeah. So, the big things are, do they have an adequate mouth opening? Can they flex and extend their necks? And, sometimes patients aren't optimal, and we can always try. And if you can't intubate with the rigid, then you place an LMA and you do what you can with the flexible bronchoscope. And then the other thing, just focusing on their teeth. We do protect their teeth, but it is a rigid tube, and you have to get. Some people have very anterior airways, so we try and limit the pressure we put on the teeth, but certainly dental fracture is a risk.
Awesome. Thank you, Josh. That was a great discussion.
Yeah, you do a good job like painting a picture of what it's like, both as the clinician and as the patient. Okay, so let's go back to this case now. So let's say that you review the scan and you see a partial obstruction of the right midstem bronchus from what appears to be an interbronchial lesion. You can see what looks like maybe a post-obstructive pneumonia distal to it. They are treatment naive. They haven't had any chemotherapy. They're not on any blood thinners. They do have some mild intermittent hemoptysis. And right now they're on 5 liters of nasal cannula to maintain their SATs above 90%. How does this change your approach to this patient, Josh?
Awesome. Yeah. So, once again, not an uncommon thing that we see. The fact that they have post-obstructive pneumonia, obstruction is always kind of a vague term. I'd be wondering how obstructed they are. And then I'd want to see the CT scan and see, what's distal to the obstruction. So we see post-obstructive pneumonia. So to me, that suggests that distal to that right main stem, there is lung that can be salvaged. So when we do, a therapeutic bronchoscopy, we want to make sure that the therapeutic side of things are going to benefit the patient. And so we have to make sure that the lung distal to the obstruction is salvageable. And so those are things that I would be thinking about. The other thing is the fact that the patient has hemoptysis. This is the real role in my mind for therapeutic bronchoscopy for hemoptysis. So when a patient has a bleeding endobronchial lesion, we can go in there and we can ablate it, and you can use a laser. There's several types of lasers: CO2 lasers, diode lasers, YAG lasers. You can use APC, which is argon plasma coagulation, like we talked about previously. So several options to control bleeding. But yeah, that would be something that would be therapeutic in the sense that we would control the hemoptysis. And then since the obstruction is severe enough that it's causing pneumonia, post-obstructive pneumonia, ideally we would be able to relieve that and relieve the obstruction. They'll respond better to antibiotics and feel better, especially given the fact that they have that new oxygen requirement.
Okay. So in a case like this, then, let's say you are, what you see is suggestive that, hey, this person might benefit from rigid bronchoscopy. So in this particular circumstance, if you were to proceed with a rigid, what are you really looking for once you get in there? Obviously, you're looking for evidence of a tumor that you can debulk. Maybe you could go into the specifics of like what would constitute success in that regard, and then other things you might be, trying to keep an eye out for.
Yeah. So, I would, as you said, plan to be doing a rigid bronchoscopy in this patient, given the findings that we've observed. During the bronchoscopy, there'd be several things. So, after, oftentimes when we start, we'll start with an LMA and a flexible bronchoscope so that we can kind of survey the lay of the land before we commit to the rigid bronchoscopy. And so the things we would be looking for are, one, is it an endobronchial tumor? Or is it, maybe we said this patient has hemoptysis. Maybe it's just a blood clot sitting in the airway or a mucus plug.
Nice.
Or maybe they aspirated a pork bone. It could be a lot of things. And so the first thing is to figure out the nature of the obstruction. And then once you're there, you have to kind of characterize it a little bit further because you want to know, is it all endobronchial or is there an extrinsic component? Because you can't recanalize the airway from extrinsic compression. We can't go out of the airway and that would certainly not be ideal. So we'd have to know that because that'll affect whether or not we would want to place a stent or just debulk the tumor. We'd want to know if it's bleeding, localize the bleeding as well to treat that. And so those are kind of the things I would look at. And then let's say, there's an endobronchial tumor. We would debulk it. There's lots of tools you can use. There's an electrocautery snare that is very commonly used. It's like a lasso that you stick around the mass if it's polypoid and able to be, I guess, lassoed. And then that allows you to both cauterize and cut the lesion out of the airway to hopefully prevent bleeding, because bleeding would be our biggest worry here. Other tools, you could destroy it with a laser. You could debulk it since it's in the right main stem. You could actually just advance the rigid bronch right into the right main stem, and then kind of just remove the tumor that way.
Smush it.
Yeah. Well, it actually, the rigid bronchoscope has kind of a tapered end, which is, kind of sword-like in a way, I guess, that you kind of twist, and maybe we can show a photo in the show notes,
Yeah.
and you can kind of debulk that way in a twisting motion. You can also use cryo debulking, which is just a cryo probe that you can remove large chunks of tumor. The nice thing about using the cryo probe is that anything that involves laser or APC is a risk of airway fire. So if you have someone who is in the ICU on 100% FiO2 that you can't wean the oxygen on, you're not going to be able to use thermal therapies. You're going to have to use, something like a cryo probe. There's also microwave that can be used, but yeah, lots of options. And so then the other thing is, let's say we completely recanalize the airway. In this patient, I would just stop the procedure. I wouldn't place a stent because it's unlikely to help them if we've completely recanalized the airway. And then stents have a whole host of their own issues. So really, we only like to place them if they're needed. If this was all extrinsic compression and there was nothing that we could recanalize, then a stent would be the answer in this case up front. So those are kind of the things that I'd be thinking about.
Great. And I love your point about the thermal therapies and oxygen point. I've done this a couple of times in the ICU where we have like a really sick patient with like a bleed or something, and cryo is your best friend because you can use it, and it's not going to be dangerous for the reason you outlined.
The only issue with the cryo probe that can come up is that it doesn't cause hemostasis. So if you have a very
Mm,
vascular lesion, although it's nice to use the cryo probe, because obviously the airway fire risk, you might get a lot of bleeding associated with that, which can be challenging to handle. So that's just one thing to caution yourself with, I think.
great point.
Yeah, it's a really good point because I think I would sort of like assume that you'd get some degree of vasoconstriction with that cryo probe, but it sounds like that's not really the case.
Yeah, certainly not as good as what you're going to get with like an electrocautery snare. Yeah.
Awesome.
All right, so back to this case. So let's say that you have successfully debulked the right main stem. Patient feels better. They get antibiotics. They go home, and then a month later, you're on call again. They've come back. They've got complete obstruction of the right main stem again. Now they're on high flow nasal cannula. They're needing more oxygen. They're feeling worse than a month ago.
Okay. Yeah. So, once again, pretty common thing that we do see. So, this tumor rapidly recurred, which is unfortunate. Oftentimes, this does happen. So things I would be considering now is since there have, being treatment refractory, they're rapidly recurring, they're, impending respiratory failure, once again, we're definitely going to have to do something. And so I would be planning a repeat rigid bronchoscopy. Now that they have complete obstruction of their airway, I would be concerned about the things we discussed earlier. So, can I salvage anything distal, or has the tumor progressed to such a degree that, the right bronchus intermedius, the right lower lobe, the right middle lobe might not be salvageable. And in that case, us proceeding with a rigid bronchoscopy wouldn't help them. Unfortunately, by reviewing the CT scan, you can't always tell. And so a lot of times you just have to go and take a look and see. And so I would be planning to do a bronchoscopy. I think it is always helpful, at least in my mind, to start with an LMA and look. But sometimes in a patient like this, who's maxed out on high flow nasal cannula, you need to be able to rapidly intervene to recanalize the airway. So in this case specifically, I think I would intubate directly with the rigid bronchoscope, because if push comes to shove, we could recanalize the airway with the rigid bronchoscope itself, even without debulking. Just push it through into the RBI, and then you have some time to come up with a plan. And then also on the CT scan, the other thing I would be looking for is the pulmonary vasculature. So squamous cell carcinomas can be quite large, and they can compress the pulmonary vasculature. And so, as you know, if there's no perfusion to that lung, improving ventilation isn't going to help. And so those are kind of things I'd be looking at. I think for this case, it'd be a rigid bronch. I would want to assess whether or not there's distal airways to salvage, and then if we could, we would do it. And then since it recurred so rapidly, I would probably plan to place an airway stent.
So before we talk about the stent, quick question, because you mentioned this a few times. So when you use the rigid bronchoscope to sort of recanalize the airway, presumably there's the possibility that a decently sized chunk of tumor is going to fall distally to the bronchoscope, to the rigid bronchoscope. I assume that then you would just use your tools to go kind of fish it out. Is that right? Or how do you approach? Is that an actual concern, or am I like overthinking this?
No, yeah, it's definitely a concern. I've had cases where, we've used the cautery snare. We've snared a large tumor that's so large and we can't even pull it out with the rigid bronchoscope, and we have to extubate the patient with the rigid and then re-intubate them. And so that's
Mm,
obviously risky, because if you debulk the tumor and it bleeds fast, you want to maintain visualization so that you can control the bleeding. And so, how I would, mitigate the risk that you talk about is, if it's in the right main stem, it's kind of nice if you can position the rigid bronchoscope right above the tumor in the right main stem. Ideally, you could actually get into the right main stem so that once you debulk it, the tumor can only go lower. And then the rigid bronchoscope itself has perforations so that the jet ventilation can get to the other lung, even while you're positioned in the right lung.
nice. Okay.
Yeah, so you kind of want to keep the bad lung isolated so that you don't then go and partially debulk a tumor and then also partially obstruct the good lung, especially in someone with respiratory failure. And so sometimes you deliberately will take out smaller pieces, and then the way you pull it out, you can use a forceps. There's rigid forceps that'll go in the rigid bronchoscope. You can also use a flexible bronchoscope with a normal forceps and pull it
So
out
so
that
so
way.
double bronchoscope,
Yes,
rigid plus flexible.
yeah, in the majority of time, we're doing double bronchoscopy, if you want to refer to it that way. We intubate with the rigid to have the flexibility of doing anything we need to do in case it happens. But the flexible bronchoscope is just such a useful tool. Oftentimes, they're used in combination. But the rigid itself does have a telescope that you stick inside the rigid bronchoscope, so you don't have to have a flexible bronchoscope. But it is nice to use both. And so,
I'm picturing like the alien from Aliens, where there's the mouth in the mouth. Like there's just a tool within a tool within a tool. Like
exactly
Yeah,
like Inception or
that's what I was
that.
thinking. Yeah,
yes,
Inception.
yeah,
It's a
yeah.
tubeception.
Exact tubeception. Yeah, and so you can use a cryoprobe, you can use forceps, you can use any of those tools to pull up the tumor. But yeah, it's definitely a consideration.
Okay. Well, thank you for educating me on that, because that was something I kind of couldn't stop wondering about, was what you would do in that circumstance. Now, getting back to this case, you'd mentioned potentially stenting the patient. We previously talked about that in the context of, okay, if they've got bulky lymphadenopathy, extrinsic compression from a tumor or whatever, you would stent them in an effort to overcome that extrinsic compression. In this case, we're saying, okay, this person's kind of had recurrent issues with certainly endobronchial disease, possibly there's an extrinsic component as well, plus minus. With that all being said, can you talk us through in some greater detail the process by which you decide on stenting the airway, and then what are the kind of unique considerations there, potential complications? What are your options for stenting an airway, etc.?
Yeah. So in my mind, the main indications for airway stents, for central airway obstruction at least, are extrinsic compression. So if you can't debulk anything to recanalize the airway, and then sometimes there's mixed obstruction. So let's say it's partially extrinsic, partially endobronchial or intrinsic. And then so if you have that scenario and you're not able to recanalize it over 50%, then you're flow limiting, and that would be an indication for a stent as well. And then the last one would be like our patient. So this guy, he has an endobronchial tumor. Let's say, it's originating from the right upper lobe and it's growing into the airway from the right upper lobe. It rapidly grows back despite him getting, first line chemotherapy, potentially radiation therapy to the region. We're going to want to place a stent because he's in respiratory failure. He has post-obstructive pneumonia. He's at risk of being intubated in the ICU with all the associated risks of that. And so it would be very reasonable to place a stent, assuming we confirm that we're able to bypass the obstruction, and that there's good long distal to the obstruction. And so there's lots of different types of stents that you can use. There's fancy 3D printed stents, which I actually haven't had the opportunity to use yet. But there's metal stents, expandable metal stents, which can actually be placed through a flexible bronchoscope. And then there's silicone stents, which do require a rigid bronchoscope the majority of the times to place. There's not a lot of evidence for stent selection, like a silicone stent versus a metal stent. There's not one that is clearly superior. It's based on the specific type of obstruction. So in this case, you have an obstruction from the right upper lobe coming down to the right main stem. You're going to need a tubular stent. And so you could place a silicone tubular stent, or you could place an expandable metal stent. The nice thing about the expandable metal stents, when they're just tubular, when it's not a Y stent, is that they have a less risk of migration. And so one of the biggest concerns about placing a stent is that it migrates. The patient wakes up, they cough, it can migrate and obstruct the good lung, it can obstruct the trachea, it can be a life-threatening emergency. The other sort of issues you worry about is when you place this stent, you're going to be obstructing the right upper lobe because it's going to go from the right main stem into the right BI in order, with the goal being to maintain patency of the right middle lobe and the right lower lobe. In this case, though, the tumor is in the right upper lobe, that we would just decide that can't be salvaged, and that is something that commonly happens. And so the other complications I would think about then would be you can have stent infections. You can have tumor ingrowth. So, tumor can grow distal into the stent and obstruct the stent. The stent itself, although we size it to the airway, there is some motion, and that repetitive trauma can lead to granulation tissue, which can also obstruct the stent, lead to post-obstructive pneumonia. And so those are kind of the main things that I think of in terms of complications. But in this patient in particular, I'd probably place an expandable metal stent, likely an arrow stent, and it would sit in the right main stem down to the right bronchus intermedius, and we'd go from there.
And I think it's important to sort of draw the distinction between the stents that are used in the lungs and stents that are used in the heart, right? I mean, those stents are permanent stents. They can never come out again, and hopefully they don't move, in contrast to what you're describing.
Yeah, no, excellent point. So, the whole goal of airway stents is they're not supposed, hopefully they're not a destination therapy. So my hope for this guy would be that, we would place it, he would get second line chemo or he would get radiation, he would have a robust treatment response, and then we'd be able to remove the stent. Because certainly the risk of stent complication is, increases with increased time that the stent is there. And so, yeah, that is definitely a good, good distinction to make.
Awesome. Awesome. So, and yeah, I'm glad you touched also on the fact that like these stents are not only removable, but the intention is to be able to remove them, because that was a question that I wanted to ask. So thanks for covering that.
We are proud to announce a new sponsor. This episode of Critical Care Time is sponsored by the Difficult Airway course.
The Difficult Airway course, Critical Care, is the premier airway management course designed specifically for critical care physicians and AGPs by practicing airway experts who understand the unique challenges of managing airways in an ICU setting.
This includes deep dives into topics including anatomically, physiologically difficult airways, rapid sequence intubation, awake intubation, surgical airways, airway ultrasound, high risk estimations, and much more.
Now, you won't just be watching folks manage airways. This course provides hands-on, evidence-based immersive training with code airway stations designed to prepare you for a wide range of situations you're likely to encounter.
Plus, the difficult airway course is taught by world renowned experts who share the tips and tricks they've picked up over many years of experience on the front lines.
Fortunately, the difficult airway course is offered twice in 2025, once from May 2nd to 4th in Boston, and again from November 14th to 16th in San Diego.
Tuition includes a copy of the new textbook, Manual of Airway Management in Critical Care. And because you are a Critical Care Time listener, you get a special discount. Use discount code CCTIME25, that's CCTIME25 at checkout and save $250. Damn, that's great.
That's awesome. Maybe you can spend some of that at our store. Hey, anyway, make sure that you check out the website, www.theairwaysite.com/critical care to learn more.
Gain the confidence and competence to manage the most complex airway cases, even when the pressure is on. Because when it comes to airway management, there is no such thing as being overprepared.
Ain't that the truth? And now back to our cases.
So once you've placed a stent, what kind of follow-up is needed? Let's say that this patient, you stent them, they feel better, they wean off of oxygen, they're getting ready to go home from the hospital. What's next for them now that they are stented?
Yeah, so, I guess since we're making the contrast to cardiology, the good news is when we place a stent, there's no need for
No
systemic
aspirin Plavix.
no aspirin and Plavix, yes, which is great in a patient with, metastatic cancer on chemo. Avoiding anything that increases the bleeding risk is ideal. And so the main thing we worry about in the short-term period after placing a stent is obstruction. And so the most common thing that would lead to, a rapid obstruction would be a mucus plug. And so these patients, after they get a stent, they'll need lifelong, or at least as long as the stent is in place, airway clearance. And so the regimens, they vary depending on institution. There's not like a guideline that tells you what to do. But what I like to do, and what I've been taught, is twice daily hypertonic saline with albuterol, and kind of go from there. And then the other thing is the rate of complications from stents, including tumor regrowth, stent fracture, granulation tissue, they can come quick, like as early as a month. And so it's recommended that they follow up in clinic within 4 to 6 weeks. And that can, the follow up also varies. What we do is we tend to get a CT scan and we use that to decide whether or not they need a repeat bronchoscopy. Some institutions and actually some guidelines recommend just doing a surveillance bronchoscopy at 6 weeks to look for stent complications. And so the right thing to do is still being worked out. But what I would do is get a CT scan and go from there.
And I think kind of the way I think about this conceptually is that like the risk of complications is kind of linear with time, right? Like the longer the stent is there, the greater the risk that one of these bad things could happen. Is that a fair assessment?
It's definitely a cumulative risk. I don't know if it's linear or logarithmic, but it's definitely increases with time. And the longer it's there, the more likely you're going to see something. The vast majority of patients have complications eventually, and so up to 90% of patients who have a stent for 6 months will have a complication, and then up to 30% of patients will have a complication within a month. And those complications can be simple, partial obstruction from granulation tissue, mucus plug, to something more significant like migration, fracture, things like that.
Man. Okay. And just to make sure that we're as granular as possible, no pun intended here with the granulation
Oh, yes, it
tissue.
was.
Okay, fair enough. I feel like as an aside, that's like the positive predictive value for pun intended when the term no pun intended is used is like astronomically high.
Yeah, it's kind of like when people say no offense, but like they're definitely about to say something offensive, and they definitely didn't
Yeah.
have to say it that way.
Right. So this is not going to be offensive. So Josh, you talked about the medications that you might use, the albuterol and the hypertonic saline, that maybe this patient would be discharged on. Let's say we discharge them home, and now they're doing their airway clearance at home. In addition to those medications, are there mechanical airway clearance adjuncts that you would kind of send that patient home with? And if so, what are the options there?
Yeah, certainly. I guess using an acapella, doing percussive devices, things like that would be reasonable. It's
Okay.
not something that we've done commonly. And so, but yeah, I mean, I think, it's certainly reasonable. I don't know. One thing I would be concerned about with the percussive device is, putting repetitive pressure on the stent, like maybe that could increase the risk of migration
Oh,
or
got it. Okay.
even granulation tissue, because if it's,
Mm.
percussing the stent against the airway, that
Friable
repetitive
tissue.
trauma, yeah, or bleeding too. I think that's another good thing to consider as well. So we
Okay.
don't do
Okay.
that, but I think it's certainly something reasonable.
I'm glad you mentioned that because I would have assumed that it would be like, yeah, they'd get their hypertonic, their albuterol, and aerobica or something like that. I would have just assumed that was like the default, but it sounds like you actually can get some mileage off of just the medications alone.
Yeah, usually patients do pretty well with just twice daily combination albuterol hypertonic saline.
Nice. Awesome. Thanks for clarifying that.
Yeah.
All right, so kind of moving this case along now. So let's say that you stent this patient, they do better, they're discharged, but then unfortunately they continue to progress over the following weeks and months. A couple months later, they're back in the hospital now with respiratory distress. They're requiring non-invasive ventilation, and they're now about to be intubated. So you're not in the room. This is some other person there. What advice do you have to somebody who is intubating a person who is known to have a stent?
Yeah, I think this is kind of, one of the main takeaway points of us doing this whole talk. So, this is not an uncommon scenario. Interventional pulmonologists, take call from home the most of the time. And so it's going to be any critical care or intensivist managing these patients overnight with limited ability to get help. And so I think that the decision to intubate a patient with an airway stent, as when it's done by a non-interventional pulmonologist or someone who's routinely placed stents should be something that's done very cautiously. And then ideally, you're able to get in touch with the interventional pulmonologist who placed the stent. And so at our institution, after we place a stent, we give the patients a card, similar to how patients with pacemakers get a pacemaker card with our phone number, so you can call us. So we can really define the anatomy. This is especially important because stents are so variable. They can be placed many different parts of the lung, so every patient with the stent is different. The biggest risk would be if it was a tracheal stent, because that would be the highest risk that you would hit it with an endotracheal tube. But this patient, if they have respiratory failure, it's possible that their right main stem stent has migrated into their trachea, and so now it is a tracheal stent. And so I would treat every patient the same and be as careful as possible. And so, ideally, if you're going to intubate these patients, after discussing the case, if possible, you're going to be using a bronchoscope and doing a fiber optic intubation, because that's going to allow you to directly visualize the airway and the stent, and then you can, carefully advance the endotracheal tube, preferably above the stent, so that you don't hit it, you don't dislodge it. Because these metal stents, they can easily bend on themselves and fold on themselves. And so, and even, the silicone stents can also fold on themselves. And so certainly you want to be careful about, dislodging them with the intubation. So that's the main thing that I would emphasize, is that doing a fiber optic intubation is ideal. So let's say you're in the ICU, this patient has a respiratory arrest. In that case, if you don't have the ability to do a fiber optic intubation, I would strongly consider doing a supraglottic airway. I think they're underutilized in general. They're very effective for oxygenation and ventilation, and it allows you time to get the tools that you need to properly assess the patient. Maybe that's not possible, but if I had to, make a hierarchy, it would be, fiber optic intubation by an experienced person, or the most experienced person available, followed by, placing an LMA or a supraglottic airway to temporize the situation to facilitate that same thing. And then last, I guess if you had to, you want to at the minimum do video laryngoscopy and be careful not to push against resistance. And so those are the big things that I would be thinking about. And for this patient particularly, given that they've really decompensated, the main things that we're hoping to fix by intubating them and doing a bronchoscopy would either be migration of the stent, occlusion of the stent, which could be, like we said before, mucus plug, tumor, or granulation tissue, or a combination of all the above, or dislodgement of the stent, which would be the most difficult thing to handle, because a mucus plug, I think anyone could go in there and suction that out. But the other things get a little more dicey.
There's two things that I wanted to touch on here. One is just really thanking you for mentioning some of those nuances of airway management in this particular scenario, because I think what you discussed, particularly the utilization, the safety profile of a supraglottic airway, is not something that we would routinely think about. I think we see someone who's in extremis, we maybe kind of like quickly review the history, scan over the stent portion of this. Maybe those of us that aren't as familiar with airway stents assume that that stent is like pretty well fixed in there. We just kind of go about our usual approach, and I think we'd be wrong to do that. So thank you first and foremost for clarifying that in a very clear and concise way. Now, the question I have, this is kind of more of a philosophical or general question that I think we talked about in pre-recording, but the classic teaching when it comes to bronchoscopy, period, in critically ill patients, at least from my standpoint, has always been you really want to avoid bronchoscopy in folks that are have a high oxygen requirement, are really kind of in extremis, high PEEP, etc. Because the moment you put that scope down, you're going to really cause problems and potentially hasten their demise. I think here, what you're getting at, and I'd love for you to comment on this directly, is that thought process really goes out the window because the theory here is that, of course, you're going to do things as safely as possible, but these interventions are designed to fix the problem that's driving the presentation. And so I think that that's a really important takeaway for our listeners is like, yes, generally speaking, you don't want to just kind of willy nilly throw the bronchoscope down all of your patients that are FiO2 90% PEEP of 24. But this is a different case. Can you unpack that a little bit more for myself and for our audience?
Yeah, I think this is a great point to make. And so, I think classically in the ICU, we're hesitant to do a bronchoscopy, because the things that we commonly see are, the patient has an infiltrate. And, the question is, can we go in there? Can we get a culture? The yield of your procedure is relatively low. Or let's say they're immunocompromised and you're wondering, is this infection? Is this, PCP? Is this some sort of pneumonitis? And, the bottom line is in those scenarios, when they're on high ventilator settings, the safest thing to do is probably just treat them all and then figure it out after. It's not the most finessed way of handling it, but oftentimes it's the safest. Central airway obstruction is a completely different beast. And so the bronchoscopy in this scenario is what's going to make the difference in outcomes. And so you'd be impressed by how robustly people do respond to rigid bronchoscopy in the setting of respiratory failure associated with central airway obstruction. And so when you look at the literature, up to 70 to 90% of patients who are intubated with malignant central airway obstruction are able to be extubated during the procedure. So once it's completed, you've recanalized the airway or you've placed the stent, they go from, high ventilator settings, dismal prognosis in the ICU to feeling great or, feeling much, much better, but sometimes discharging home the very next day. Yeah, I've seen that several times, and so I think it's important to realize that there is in this case particularly when you have a very good chance of improving the outcome, you have to accept the risk. The things that we will be less likely to accept would be hemodynamic instability. If they're in shock, we're not excited to do a rigid bronch. But if respiratory failure is the issue, I think bronchoscopy is the answer in the setting of central airway obstruction. But once again, you got to carefully select your patients. But I really do think the outcomes are a lot better than at least what I expected before I started as doing interventional pulm.
I think that's a great point, and I really want to, emphasize that to our listeners that like this idea that this person is too sick for a bronchoscopy is really they're too sick for a diagnostic bronchoscopy. That therapeutic bronchoscopy, as you said, is a completely different beast. Like it is the treatment for the problem, right? And so you shouldn't delay the definitive treatment, especially because, as you point out, 70 to 90% of patients can be extubated after debulking with malignant central obstruction. That's a very, very impressive response. So this is a great case. We sort of walked through from sort of initial presentation, initial debulking, stent placement, potential complications of stent, and intubation. That, by the way, is incredibly high yield for our listeners. Let's kind of, now sort of conclude this case by saying, like, what does the long-term outcome look like for somebody like this?
Yeah, I think, as with any procedure in the ICU or in the bronch suite, we always have to think about the risk benefit. So if we're doing something that's relatively risky in a patient who's sick, how much are they likely to benefit? And so this was actually The AABIP, which is the organization for interventional pulmonologists, just shared a journal club that kind of looked at this issue particularly, and they found in the study that they summarized was that the median survival following a tumor debulking was 63 days overall, and so that includes patients who were candidates for treatment, like further cancer-specific therapy. That's kind of what I was talking about at the beginning. So if this person is still treatment naive, they're about to get first line chemo, and the cancer is going to have a significant and robust response, and much better if they're on fourth line. Still overall average 63 days, which is, I think, meaningful. 2 months with your family, that might be the difference between seeing Christmas, meeting a grandchild, going to a wedding. I think that's certainly impactful. But for patients who are candidates for treatment, it can be 216 days on average in the study that we'll include in the show notes. And then, in that study, they looked at how many of the patients were candidates for therapy if they've already developed malignant central airway obstruction causing respiratory failure. And over half of those patients got treatment. So certainly, I think the outcomes, obviously in the setting of understanding that they do have metastatic cancer that is going to limit their lifespan, I think it's overall quite good. And it's something that's worthwhile.
I think, Cyrus and I often talk about this sort of like misplaced nihilism we sometimes see in the ICU, where people will say things like, what's the point? This is metastatic cancer. And I think you make a great counterexample there, which is that you can give this person a lot of time and a lot of high quality time, potentially. And it's also worth pointing out that medians are just that, that there are going to be people in there who have a much longer, much more robust response. I cared for somebody the other day who had like 7 years of non-progression on an EGFR inhibitor, which is like a game changer in the lung cancer world.
Yeah. Yeah. The patients that have driver mutations, fantastic outcomes.
ALK, KRAS, all of these things are now druggable.
Exactly. And, I think the targetable mutations are increasing with time too. So, at MD Anderson, they're trying to make cancer history, and I think they're going to get there with time, hopefully. So, but yeah, to your point about the nihilism that we see in the ICU, that's something that I've witnessed too. And I really do think, and once again, this is me standing on my soapbox as a, junior intensivist. I think that we kind of have to be rooting for our patients. Like we have to be the ones that are going to give them the benefit of the doubt and not throw in the towel too soon. And conversely, I understand that we don't want to be doing things that are unnecessary or futile. But I think it's important to always try and look at it from the patient's perspective. So, like I said, 60 days could mean the world to a patient, and to other patients it might not. But certainly, I think it's important to discuss these cases with interventional pulmonologists before, considering withdrawal of care or anything like that, because the outcomes are quite good, in my opinion.
Excellent, Josh. Thank you for, walking through that and closing out the case. And yeah, I think I have to agree, I've certainly been guilty of this myself, sort of like projecting my own values or sort of like goals for a patient onto them. But the reality is, 30 days, 60 days, whatever, we kind of, as the outsider looking in, we have really no concept, no leg to stand on with respect to how important those 30 or 60 days could be for a patient. And so, it's great to know that colleagues like yourself are people that we can lean upon when situations like this arise to sort of give that patient at least the opportunity to have that extra time with their family. All right. So, Josh, we spent quite a while now talking about central airway obstruction. But of course, as we sort of alluded to in the beginning of our show, there are other places where interventional pulmonologists and those skills can come in handy, particularly amongst the critically ill. We did touch on some of this again in our prior episodes with, your mentors and my mentors, Doctors Warren and Sobieschek. But, I was kind of thinking as we were putting this together that maybe we could make this opportunity a little bit of an IP potpourri for listeners who might want to really have a one-stop shop, if you will, for scratching the surface. So maybe we can kind of move into the last phase of our discussion, which is a little bit more of a rapid fire, talking about a few shorter cases. And the first one I thought we could talk about would be the following. So let's say we've got a 54-year-old lady. She's got COVID ARDS. She's been on mechanical ventilation now for 12 days. She has made some progress, particularly over the last few days, but it's pretty clear, I won't belabor the point. It's pretty clear that she's going to need to be on ventilation for a while longer. We don't know how long, but looking at, weeks to maybe a month or longer. And so invariably the question comes up, okay, is this a good candidate for a tracheostomy? I think we'd all agree, assuming that that's consistent with our goals of care. Yes, tracheostomies can allow for reduction in sedation needs, more mobility. All these things are really important for our patients if we're kind of doing right by them. So now the next question is, how are you going to do it? And so, I think again, as pulmonologists, we're probably all fans of the percutaneous tracheostomy in the appropriate patient. But that's not always how it's done. Certainly not always how it's done. And so, Josh, I was hoping maybe you could talk to us a little bit about the perc trach approach versus the traditional surgical tracheostomy approach, and maybe just share your 2 cents in terms of like, when you might opt for one, what the benefits might be of one over the other, and what are the kind of pitfalls and pearls there that we need to be aware of.
Yeah, no, I think this is a great thing to discuss. So, I think the main, I guess, just kind of getting right to the point, I certainly only perform percutaneous tracheostomies. So I tend to have that bias. But the literature, we have some data to go over that kind of goes with that. And so percutaneous tracheostomy, the main benefits for the patient, it's done bedside. So you don't have to breathe them to the operating room, less risks of, tubes getting dislodged, all of those things as they get transferred. But, the main things that the literature have shown that, a benefit associated with perc trachs, it's faster and there's fewer complications, particularly infection. Compared with surgical tracheostomy, the things that surgical tracheostomy tends to be better suited for. So you always have to consider your anatomy whenever you're planning a procedure. So you want to make sure that the patient has, decent anatomy to do the procedure percutaneously, because you're not going to visualize the tracheal rings when you do this. And so, can they extend their neck? Are they in a C collar? If they're in a C collar, I think they're probably not the best candidate for a percutaneous tracheostomy, although it can be done. Other things to look at is look at the CT scan or take out your handy ultrasound before you do the procedure. Look for a high riding innominate artery or prominent vasculature that you might end up, encountering as you do the percutaneous tracheostomy. So I guess to get to the main point, I think perc trachs, less infection, faster, can be done bedside. I think cosmetically it leads to a better outcome. Advantages to the surgical trach would be difficult anatomy, and then I think there is some data that looks at like trach dislodgement and trach obstruction being less in surgical tracheostomies. But overall, I think in most patients, percutaneous tracheostomy would be what I would go with and recommend.
Excellent. Yeah, I think that's a great summary. And I think one of the key things we forget is that like sometimes perfection is the enemy of good. That like a surgical trach next week versus a perk trach now, potentially gets you 5 days with less sedation and more mobility and like just like a lot of opportunities to improve care by doing the procedure promptly.
Yeah, for sure.
I just maybe this is unique to my shop, but I always feel like it's like, getting the get a surgical trach on the schedule is always like this lag time. Oh, add-on case day after tomorrow, as opposed to perk trach, which is often like, sure, we can do it right now. Anyway, so great points about perk trachs. Let's switch gears and discuss another area where your skill set could be particularly helpful: pleural disease. So let's say we've got a patient with right lower lobe pneumonia, hospitalized now on day 4, and they're kind of stuck. They're not getting better. You go to the bedside, you ultrasound the lungs, and you see a large septated fluid pocket with plankton sign present in it. So listeners may remember from our pleural disease episode that this is very worrisome for empyema. At this point, let's just say, Josh, we haven't sampled the space, but we're kind of worried based on its ultrasound appearance. What would you do in this case? Like, what would you jump to a surgical thoracostomy tube? Would you do a smaller tube? How would you, as an interventionalist, approach this, and how might that be different than somebody else? Let's say.
Yeah, so I think all pulmonologists, we're going to review the CT scan, we're going to perform an ultrasound, kind of assess what stage of empyema we're looking at here. So is this thing fully consolidated or is there just some small loculations? That's all going to affect the approach. But I think the first step is a diagnosis. And so oftentimes in this case, when you have such a high probability of empyema, I think the least invasive thing actually is just to place the 14 French chest tube up front. And so, I don't think the risk of a 14 French chest tube compared to, a thoracentesis, which I think is like 8 or 9 French, is that much more. And it saves the patient a second procedure. And then other things I've seen is, someone will, let's say it's a loculated effusion, so you're not going to be able to drain all the pockets. They don't communicate. They'll do a thoracentesis, drain the good pocket, and then you won't have a pocket to place your pigtail. And so I think sometimes, especially in a patient that has a really high probability of having a complicated space, it's best just to place the pigtail up front. I can't think of a scenario where I would use a large bore chest tube up front. I think a 14 French to 20 French, depending on the type you're trying to do, would be, as big as I would go to start. But I think, one of the things I would like to discuss, we've all, read the MIS2 trial. The use of TPA and Dornase improves the radiographic resolution of empyema. That was kind of their primary outcome in that study. And so I think an additional tool that might be available and, which people have talked about is doing a thoracoscopy, or which is also referred to as a pleuroscopy, medical pleuroscopy versus thoracoscopy. So patients that have that stage 1 and stage 2 empyema, where it's not completely consolidated with fibrinous debris, they have loculated collections that don't communicate, and maybe you have the chest tube in, you've done your 3 days of TPA Dornase, and they've been refractory to that. I think it'd be reasonable, and there's emerging literature to support this, to do a thoracoscopy. And the purpose of that would be you would break up the adhesions and drain the infection adequately before it develops to, the third stage of empyema, and then they're going to need decortication or something more invasive. And so, there's a meta-analysis. The data isn't great. It's mostly retrospective. Most of the studies are relatively small, and certainly more evidence is needed. But I think it's very reasonable if, after placing a chest tube, and then, I think it's up to debate, should you trial, TPA Dornase first or second? It's hard to say. But after doing that as a second line maneuver in patients with that stage 1 to stage 2 empyema, to consider doing a thoracoscopy, which basically it's a very simple procedure. It can actually be done under just local anesthesia. Patients can be awake, which is nice. But this patient, if they're in the ICU or something, it wouldn't apply to them. But you numb the skin, you cut down as if you're going to place a large bore chest tube, and then you insert a trocar through that. And then you can then put multiple tools. You can do a fluoroscope. They have rigid ones, they have flexible ones, different tools to take a look in the thorax. The lung will, collapse, and then you can take down adhesions. You can guide your chest tube placement to an optimal spot. Really, just evacuate as much of that infected space as you can. And so the studies have shown, success rates of the high 80% for complicated periodontic infusions. And so I think it's something, it's not any guidelines to date, but something to consider, and it is an option. And it's relatively safe. The number of infections are very low, especially since we're planning to, I meant the number of complications is very low, especially since we're planning to place a chest tube anyways. And they've already failed the first line therapy.
I think those are great points. Yeah, I think, IP is your resource. If you have it at your institution, you should involve early in these cases. Potentially, like you said, that doing that diagnostic thoracentesis can give you a diagnosis, but it can complicate further therapies if it's harder to, like, if the good pocket is drained, as you said. And then, yeah, I like the idea of, being appropriately aggressive about resolving this quickly before it progresses, because you're ultimately saving this person a lot of, a lot of procedure down the road by not doing it up front. So great overview.
Yeah, I think someone famously said, "Never let the sun set on an empyema." I don't know who said that or who it's attributed to, but
It's funny because I feel like there's a lot of these aphorisms that are like, never let the sun rise on a appendix or whatever. And nowadays, like, we just sort of let the Zosyn treat the appendix like a third of the time. So I don't know how many of these are true, but yeah, it's good aphorism. I like it too.
And I think before, just before we get on to the next couple cases and kind of finish out our discussion with you, Josh, as a reminder to our listeners, I know a lot of the folks that are listening to this are not interventionalists, but from my standpoint, I think it's very important as a general pulmonologist and an intensivist to know, hey, if my TPA pulmozyme fail, I don't necessarily need to call the CT surgeon to just decorticate this patient or to consider a VATS. Like there is actually a potential alternative that can be utilized. And furthermore, that alternative could even be utilized up front, or in concert with your chest tube. Basically just trying to say here that, this is a nice additional tool that some of us might have access to at our institutions. And so I'm glad you shared it with us, because it's not something I immediately think of for the management of these cases. And as you said, not guideline driven per se, but just because it's not guideline driven, it doesn't mean we should ignore it. Okay, so moving on, like I said, a couple other cases left. This one I wanted to ask you about is actually continuing with the theme of pleural disease. We kind of touched on this a little bit with Dr. Sobieschek last time we chatted about pneumothoraces, but I wanted to get your thoughts here. So suppose we're rounding on a 27-year-old male had a gunshot wound to the left chest, complicated by tension pneumothorax. Initially, the patient received a needle decompression in the field, came to the ER, and they still needed to have a pleural drain in place. They just weren't able to tolerate removal of that decompressive device. So they come in, they've got the drain in place. Initially, it's on water seal, but water seal's not doing the trick. And so you're starting to wonder, okay, does this person have like a persistent air leak that needs to maybe be managed with some suction? You try some suction, still not doing it. And here we are, day 5, day 7, or something like that, not able to liberate that patient from the quote unquote pleurovac, from the pleural drain, not able to liberate them from suction. And so the question is, what do we do? Because we're sort of getting now into that neighborhood of persistent air leak, with concern for bronchopleural fistula or alveolo-pleural fistula, depending on the anatomy there. And so, typically for our listeners who may be familiar with this, your options might be talking to your general surgeon or a thoracic surgeon about doing a thoracoscopic procedure. You could do kind of maybe stapling of the region that is affected. You could consider doing mechanical or chemical pleurodesis. You could consider an autologous blood patch. You could instill kind of the patient's blood through the chest tube and try to hope that allows that defect to kind of close off. But I think there are some other things we could consider as well, Josh. And so I was hoping, A, you might, lend your thoughts on those options that I described, and B, let us know what I might be alluding to.
Yeah. And so I think this is once again a commonly encountered scenario in the ICU: persistent air leaks. Post-operative patients, or patients that have had trauma or chest tubes placed and have had damage to the lung as a result of that. And so you talked about many different options. And so blood patches, I haven't done it too much, but one of the major issues that you would encounter is if you're going to instill the blood into the pleural space with the hope of treating the air leak, you're going to have to clamp the chest tube so the blood stays there. And so if they have a large volume air leak, they're probably not going to tolerate prolonged clamping of the chest tube. They'll develop tension physiology. So it sounds great in theory, but practically I haven't found it particularly useful personally.
It's good for somebody who doesn't have a bronchopleural fistula.
Yes.
Essentially.
Yeah.
Or a very, very, very small one. Yeah.
Very, very small one. And, to the point of, the magnitude of the air leak, there's a great tool that I've started using recently called the Topaz device. Have you all heard of the Topaz?
No,
you have
tell me.
those? Yeah. So a Topaz, maybe we can include that too. You hook it up like in series with the chest tube, and you can actually quantify the air leak in like mils per minute or liters per minute. And then it'll also quantify the output. And so it's great for having an idea of how severe the air leak is, but then also when you're considering placing endobronchial valves, which is the procedure Dr. Askin was alluding to, we have to do a balloon occlusion trial. So we're not just going to place valves and expect them to work. So we have to do a bronchoscopy and then sequentially occlude airways to see if we're able to make that air leak go away. And so let's say, I forget what side this chest tube was on. For the sake, I don't think we know. So let's say it's the right side. And so, how you would start, or how I would start that, depending on, their oxygenation, all of that, is just occlude the right main stem and see if you occlude the right main stem and the air leak goes away. Then that we can solve this potentially. And then after that, you would go to the right upper lobe and you would try each segment. And, oftentimes for the, being fast, I would just do the whole upper lobe and see if the air leak goes away. If it doesn't, then that valving off each segment individually isn't going to help. And so then the next step would be to do a balloon occlusion of the bronchus intermedius. And that'll tell you, let's say the air leak resolves there. So then the question is it just the right middle lobe, or is it the right middle lobe and right lower lobe, or is it segments of each? Because
This
often,
is like a game I play with my kids where it's like warmer, colder, warmer. Like you're sort of zeroing in on which airways may lead to this.
exactly. And the other thing that I have encountered that's important is to make sure that your chest tube atrium is connected well. Because sometimes the leak is actually
Yeah, air
from a loose
entrainment.
connection. Yes, exactly. And so I think it's important
It's
to,
really embarrassing to consult IP to fix your atrium.
Or for that matter, if the chest tube itself kind of dislodges a little bit and now you're
Just
entraining air through
sucking
one of the
environmental air.
fenestrations. Exactly.
exactly.
So a question for you. Do you have the Topaz device on while you're doing this so you can quantify?
Yes, and we'll have it on a screen. So you know how you have your bronch screen? You'll have the Topaz on the other. You'll inflate the balloon, and then you'll watch it go down. Hopefully that's the goal. And it's just a number. It's an analog screen, and it'll go from, let's say, 4 liters to 200 cc's to gone. That would be the ideal scenario. And so in our patient, we know that if we include both the lower lobe and the middle lobe, we control the air leak. And so we certainly can valve the entire lower lobe and middle lobe. And probably, since he's 27 years old with healthy lungs, he's going to do fine. And these valves too, they're just little umbrella valves that are easy to remove. They're not very invasive. So I think oftentimes it's important to know it's a very simple procedure, and it's something that's very reversible as well. And so, but the next step would be to go to the right middle lobe. You occlude that. If let's say the air leak completely resolves, then we know that we could just place the endobronchial valves in the right middle lobe. And we'd also do the subsegments, because sometimes maybe it's only the medial subsegment. It's one single valve to fix the whole thing. Other times it's both, and you have to place a valve into the entire right middle lobe. And so you place those, and then ideally the leak resolves. But if you get a good, robust decrease, and that's why it's nice to have the Topaz, sometimes you don't completely resolve the air leak, but you resolve it enough so that the patient gets pleural apposition, and then the rest of the healing can be done by itself. Or you could do some sort of combination therapy in theory, like you could do a pleurodesis in addition to the valve. Or you could do this blood patch. There would be multiple ways to handle it. But I think endobronchial valves are very good for this indication. They are, FDA approved under, I forget, it's called like an emergency use authorization or something like that. And it's specifically the spiration valves, I believe. Correct me if I'm wrong on that. The umbrella valve specifically. And the data is pretty good. Resolution of air leak in up to the high 80s percentage of patients. Decreased duration of air leak, increased chest tube removal time, decreased length of hospital stay, all those things. So good outcome.
It's a humanitarian device exemption.
Okay. And it was the spiration valves. Is that correct?
Yes, exactly right.
Perfect. I just wanted to make sure I wasn't giving fake news.
Awesome. No, thanks. And I'm sure, Josh, I know we could talk a lot about the different kind of complications related to valves and things to look out for, which maybe is going to be a topic for another day, just in the interest of time. But Nick, I think we got maybe one other case that we could touch on.
I think we got to get you back to your family. They're breaking down the door to get some attention from Dad. But before we do, one more case, just one more. So back when we were talking to Dr. Warren, way back when in season 1, we had this case of a 62-year-old woman with a prior diagnosis of endobronchial carcinoid, admitted with post-obstructive pneumonia, and then developed massive large volume hemoptysis. Does not have a protected airway yet. You're concerned that the volume of hemoptysis is going to lead to significant aspiration. How do you approach a case like this? In the limited time that we have left, what's your kind of IP brain say to do in a situation like this?
Yeah. So, in brief, I think the main role for bronchoscopy and massive hemoptysis is when there's a bleeding endobronchial lesion. So this patient has a carcinoid tumor that's likely bleeding, presumably at least. And so it's kind of like central airway obstruction, that bronchoscopy is the maneuver that's going to fix the issue. And so I think it's important to do that. So in this case specifically, I would have a low threshold to take the airway. I know oftentimes, in hemoptysis, you think that the easiest way to clear the blood is to not take the airway, allow them to cough it up. But in this scenario specifically, assuming it's large volume and they're symptomatic, doing intubating them, putting the bad lung down to optimize the good lung, and then doing a bronchoscopy would be ideal. And so what we would do, depending on the location of the endobronchial lesion, we'd go look. You can place a blocker to temporize the patient, and I think that's a skill that all intensivists should have, is placing an endobronchial blocker, because it really is a life-saving maneuver. And then, ideally we're able to identify the source of the bleed and treat it. And so how we would treat it, once again, we'd use the same tools we discussed previously, and it can all be done through a flexible bronchoscope. You don't have to do a rigid, but it is nice to do a rigid a lot of times. But you can use APC, you can use laser, you can use a cautery snare, all of those things. You could even tamponade it off with the balloon directly with the rigid itself if you end up doing that. And so I think it's important whenever you have endobronchial bleeding to consult IP if there's an airway tumor, because there's something that likely we can fix.
And importantly, even when you can't fix it, sometimes just locating it helps IR, right?
Yeah, oftentimes, yeah, but a lot of times we'll get consulted, and there's maybe bronchiectasis with cavitary lung disease, or there's cancer that got radiation and now they have a cavity there, and the writing's on the wall for where the bleeding's coming from. And in those scenarios, I would more consider just empiric embolization, bronchial artery embolization, as opposed to taking the airway. I mean, once again, you have to analyze every case on a case by case basis, but certainly it is nice to localize it. But it's one of those things where, once again, what we're talking about is the juice worth the squeeze,
Mm,
because oftentimes you can't tell, or there could be collateral ventilation and you're bleeding from two different lobes, and
mm,
so the likelihood of changes management might be less. And
mm.
so in those cases, I might just consider empiric bronchial artery embolization.
Excellent.
And then the one thing that was IP, sorry, I don't mean to prolong this, that
Please.
I did want to talk about is the use of endobronchial valves. So let's say this patient has a right upper lobe cavitary lesion, you localize the bleeding to that. What are you going to do? And so bronchial artery embolization is the first line answer. But sometimes it doesn't work as well as you might hope. And, there is some limited evidence for the use of endobronchial valves to manage this. So you would just, let's say it's coming from the anterior segment of the right upper lobe, you place a valve there, the blood clots, the bleeding stops. It's kind of, therapeutic in itself. It's something to consider. Once again, some of these things that we're talking about, they're not guideline based and they're even off label, but I think certainly IR is best, but it's another tool that you have in your toolbox to consider would be an endobronchial valve.
Excellent. Well, thank you so much, Josh, for sort of walking us through these cases, walking us through what the tools are in the toolbox and how you approach it. I mean, I think the big takeaway for all of us is, IP is a resource. Use them whenever you have one of these challenging cases. I think you made some great points about times when you absolutely want to have IP helping you. Situations like massive hemoptysis, maybe your approach to suspected empyema, and certainly whenever there's a doubt about the placement of an airway stent, definitely want to have them involved. So thank you so much for walking us through. Cyrus, any concluding thoughts?
Nick, I think you hit the nail on the head there. Josh, thank you so much for spending your time working on this from kind of soup to nuts with me. And then also, presenting this data based upon your experience as a kind of budding interventional pulmonologist now towards the kind of latter half of your training at, again, a world-class institution where I know you're getting tons of great cases, great experience. I think hopefully our listeners have learned both about all the skills that you bring to the table, but also maybe even more importantly, when to call you, when to engage you, and how that sort of synergy can be in the best interest of our patients. Once again, Josh, thank you so much for your time. We sure appreciate you and all the work you've done on this episode and with the podcast. And to our audience, please, if you listen to this and you enjoy it, leave us a review. Let us know what you think. You can listen to this through, of course, your favorite podcast app. You can watch us on YouTube, and you can check out our show notes at www.criticalcaretime.com.
As you heard us say many times in this episode, there's a lot of great stuff there. There's pictures, there's references, there's a lot more to learn there. So listen to us and then read and then leave us a 5-star review.
Yes, please. Yes, please.
Hope you enjoyed the show. If so, make sure you subscribe, give us a like, give us that review. We also love to hear from you. So give us, a tweet or an X or whatever, at Crit Care Time, at Nick M. Mark, at Askins_Razor. We're also on Blue Sky, Instagram, Threads, YouTube, etc. You can also leave comments on our website, I suppose.
Absolutely. And Josh, before I forget, where can our listeners find you on social media? Anything you'd like to plug before we sign off?
I have a very meager Twitter following, but I do. I guess it's X. I apologize. But yeah, it's at Josh Boster. You should be able to find me. So I sometimes share some interesting stuff, but not too much.
Awesome. Great. And with that, we of course want to also take a moment to thank our sponsor, C-Star Medical. So we're fortunate and grateful that this episode and all episodes of season 2 are sponsored by C-Star Medical. C-Star Medical is advancing the science of cell-directed extracorporeal therapy to help restore the balance of a dysregulated immune system in acute kidney injury and sepsis. Check out their website, cstarmedical.com, to learn more.
Also, a big thanks to our production team for making this show possible. The folks over at Podpaste for editing, Kurt Belknap for our music, and then of course all the people behind the scenes helping us write these episodes. People like Josh, who you just met.
Yes, sometimes the folks behind the scenes come on the scene, so that's always exciting. Awesome. And so we did talk about some cases here today, and of course the views expressed within this podcast and any associated media don't necessarily reflect the views of our employers with respect to those cases or really anything else. And of course those cases, if they sounded like a real...
They're make-believe.
Exactly. If they sounded like a real world case to you, well, they weren't. They were at the very least modified to be HIPAA compliant, and thus any similarities to those real world cases would be purely coincidental. Finally, this podcast is for educational and entertainment purposes only and should not be used in lieu of seeking medical advice. With all of that said, thank you guys so much for listening. Again, thank you, Josh, for your time, your blood, sweat, and tears. I am, once again, and I think always will be, Dr. Cyrus Askin.
And I'm Dr. Nick Mark. Thank you all so much for listening. See you next time.